The first presentation, I invite Dr. Smitha to present on cup disc acid glaucoma. Over to you, Dr. Smitha.
Thank you, KSOS and Dr. Gija for giving me this opportunity. My topic is cup disc acid glaucoma. Cupping is described as an enlargement of the cup to disc ratio. It's a well-known feature of glaucoma. Diagnosis is easy when the IOP is high and there is glaucomatous cupping, but it becomes a problem when the IOP is normal and there is cupping. 20% of non-glaucomatous conditions are misdiagnosed based on large cup disc ratio. The typical features of glaucoma are enlarged vertical cup disc ratio. The inter-eye cup disc asymmetry is more than 0.2. Normally, in the optic disc, the Ising rule is obeyed. That is, inferior rim is thicker than superior, then nasal, and thinnest is temporal. While in glaucoma, this is violated. And there will be focal or broad notch. Disc hemorrhages can be seen. This is more commonly seen in normal tension glaucoma. It is seen more in the inferior or superior rims and is usually perpendicular to the disc. And RNFL defects, which are wedge shape, which extends from the disc and spans out peripherally, is common in glaucomatous condition. If there is any cup disc ratio asymmetry in both eyes, we have to assess the disc size. In this patient, the left eye has more cup disc ratio, but the left eye disc area is more. The conditions that can mimic glaucomatous disc cupping are congenital conditions like tilted disc, optic disc glaucoma, optic disc peaked, morning glory anomaly, neuro-ophthalmological disorders like intracranial tumors, hereditary optic neuropathy, ischemic optic neuropathy, toxic nutritional optic neuropathy, high myopia, optic neuritis, and retinal diseases like RP, BRVO, CRVO, etc. In optic disc glaucoma, you can see a clearly delineated wide bowl-shaped excavation with thin or absent neuroretinal rim, and the blood vessels originate from the periphery of the excavation. Here there is an inferior excavation with a corresponding superior field defect. In optic disc pit, you can see a large disc with grayish round or oval pit. The pit is usually temporally located with temporal pedipapillary atrophy, and OCT can show neurosensory detachment. In morning glory anomaly, there is a large size disc with a central glial tuft. There is increased number and radiant blood vessels emanating from the central glial tuft. And there is annular pedipapillary chorioretinal atrophy with corresponding enlargement of the blind spot. In superior optic nerve hyperplasia, otherwise known as topless disc syndrome, there is pallor of the superior optic disc with peripapillary scleral halo and thinning of the superior RNFL with corresponding inferior visual field defect. The central retinal artery has a relatively superior entrance to the eye. In megalopapilla, there is a large optic disc with large cup. There is no neuroretinal rim thinning or visual field defect. In high myopia, the disc can be large with more shallow and thinner cup, shallow cup with thin neuroretinal rim. The disc may be tilted with peripapillary atrophy. Visual defects can mimic that of glaucoma. That is, there may be a large blind spot caused by the large peripapillary atrophy, arcade scotomas by tilted disc, and paracentral scotomas due to chorioretinal scars can be seen. In retinitis pigmentosa, there is diffuse waxy pallor of the disc and the cup is not well delineated, and there is vascular attenuation and bony speckle pigmentation. In CRVO, there is diffuse pallor of the disc, and BRVO and BRAO, there will be localized pallor and cupping with associated no fiber layer defect. Intracranial tumors like chiasmal and pre-chiasmal tumors can have optic nerve changes. These include pituitary tumor, craniopharyngioma, optic nerve sheath meningioma, etc. Here, pallor of the rim is more than cupping. Detailed history, age of presentation, loss of central visual acuity, color vision defects, RAPD, field defects respecting vertical meridian, and neuroimaging helps us to get into diagnosis. Here, this is a patient with pituitary adenoma with bilateral disc pallor, and there is no PL in the left eye and right temporal hemifield defect in the right eye. In optic neuritis due to multiple sclerosis, there is temporal disc pallor and relatively good visual function. Central scotoma may be seen in HFA. And in neuromyelitis optica, there is marked disc pallor and subnormal visual function. In hereditary optic neuropathy, there is temporal disc pallor with central or centrocecal scotomas. In non-arteritic anterior ischemic optic neuropathy, there will be sectoral disc pallor associated with retinal blood vessel attenuation, and the fellow eye has a small disc or disc at risk. In arteritic ischemic optic neuropathy, there is moderate increase in cupping and diffuse pallor. Nutritional and toxic optic neuropathy, they are usually bilateral with color vision loss out of proportion to the central vision, and temporal pallor of the disc is seen. The papillomacular bundles are usually affected first. In traumatic optic neuropathy, there is gradual increase in optic disc cupping, temporal pallor, and mild attenuation of blood vessels can be seen. Glaucoma can coexist with this condition. So, glaucomatous optic neuropathy is seen more commonly seen in aged patients, while non-glaucomatous optic atrophy is seen in young people. And central visual acuity is affected early in case of non-glaucomatous optic neuropathy, while it is spared till end stage in glaucoma. And RAPD is seen early in non-glaucomatous disease, while in advanced cases in glaucoma. And pallor more than cupping is a feature of non-glaucomatous optic neuropathy, while in glaucoma, cupping more than pallor is seen. And wedge defects more commonly in the superior and inferior vascular arteries are seen in the glaucomatous optic neuropathy, while NFLD more common in the papillomacular bundle in non-glaucomatous optic atrophy. Field defects respecting horizontal meridian is seen in glaucomatous optic neuropathy, while field defects respecting the vertical meridian is seen in compressive optic neuropathy. And glaucomatous optic neuropathy is usually bilateral, while non-glaucomatous optic atrophy is usually unilateral. So in conclusion, glaucoma diagnosis should not be based on any single parameter like optic nerve head cupping. The decision making should be based on patient's history, clinical examination, ancillary testing such as visual fields, OCT, and neuroimaging. Thank you.
Thank you, Dr. Smitha, for that wonderful discussion on the common dilemma that presents to every of the